To the Kanski lecture series Cornea Part 9. In this part, we are going to discuss about the herpes zoster ophthalmicus, HZV, herpes zoster virus. So it is basically the virus that infect the cornea. It has two stages. The primary stage in which the herpes, the where there is a chicken pox, it is called varicella, and in the second stage it has a shingles, which is called as herpes zoster. Now we will see what's written in it. Herpes zoster ophthalmicus. Herpes zoster is common, and it has been estimated that one of the three people will develop the condition in their lifetime. Most patients are not immunocompromised. It means that it is very common in an immunocompetent person, and also 1 in 3 person will get affected. So it can see how important this is. Pathogenesis. Herpes zoster ophthalmicus is the term used for shingles involving the dermatome supplied by the ophthalmic division of the fifth cranial nerve. So basically, when the virus that is affecting the, so you know that in case of trigeminal, it has a three branches: V1, V2, and V3. The V1 is ophthalmic, and number 2 is maxillary, and number 3 is mandibular division. So when this affect this dermatome, this is called herpes zoster ophthalmicus. Ocular involvement can also occur, although is rarely clinical significant when the disease of affect the maxillary division alone. So in case of maxillary division, there is some ocular involvement, but it is not very significant. Varicella zoster virus causes both chickenpox and shingles. VZV belong to the same subfamily of the herpes virus group as HSV. The viruses are morphologically identical but antigenically distinct. So you can see that it is anatomical structure is the same, but its antigenic property is different. So just remember this line, it is very important. So as I told you, herpes simplex virus, when it causes a primary infection, when it is a primary infection, it causes chickenpox, and when it recur, it causes shingles. After an episode of chickenpox, the virus travel in the retrograde manner to the dorsal root and the cranial nerve sensory ganglion, where it remains dormant for decades, with the reactivation thought to occur after the VZV specific cell mediated immunity has faded. Re-exposure to VZV via contact with chickenpox or by vaccination may reinforce immunity and protect against the development of shingles. So in this case, the writer is trying to say that when a person get infected with the chickenpox, he is being infected by the HCV virus. His virus will travel through the dorsal root, and it will remain in the sensory ganglion of the cranial nerve. And then what happen? It will remain latent there, but it will get reactivated when their immunity is being faded. Mechanism of ocular involvement. Now in this part, how the virus causes the ocular involvement of this. Direct viral invasion may lead to conjunctivitis and epithelial keratitis. So when a cornea is being exposed directly to the virus, VZV, it causes conjunctivitis and epithelial keratitis. Secondary inflammation and occlusive vasculitis may cause episcleritis, scleritis, keratitis, uveitis, including segmental iris infarction, optic neuritis, and cranial nerve palsies. So it is very it causes a number of distinct diseases. Inflammation and destruction of the peripheral nerve or central ganglion or altered signal processing in the central nervous system may be responsible for the post-herpetic neuralgia. Cicatrizing complication may arise following severe eyelid periauricular skin and conjunctival involvement. So in this case, the writer is trying to say that if in a secondary inflammation, when the patient is infected secondarily, it can also causes occlusive vasculitis. Very important. And it causes episcleritis, it can cause scleritis, it can sclera, it can involve the cornea keratitis, it can call UVI, it cause uveitis. So it causing inflammation in everything, optic neuritis, cranial nerve palsies. And it is because of this inflammation and destruction of the peripheral nerves that is responsible for the post-herpetic neuralgia. Post-herpetic neuralgia is when there is a very deep or sharpening pain in the dermatome that is involving the that involve the herpes virus. And cicatrization complication occur when there is a very significant amount of conjunctival or the skin involvement. And in second, another case is reactivation. Reactivation causes necrosis and inflammation in the affected sensory ganglion, causing corneal anesthesia that may result in neurotrophic keratopathy. So that is the mechanism how it causes the neurotrophic keratopathy, because it causes the necrosis of the involved sensory ganglion. So that is why it causes the corneal anesthesia. And when there is a corneal anesthesia, there is a loss of sensory sensation of the cornea, it resulted neurotrophic keratopathy. Risk of ocular involvement. So what are the risk of ocular involvement? It's very important sign. So what are the risk factors? Risk factors mean what signifies that if this sign is present, then there is a more chance that there will be the ocular involvement. One is a Hutchinson signs. Now, what is a Hutchinson signs? It describes the vesicle in the skin supplied by the external nasal nerve, a branch of the nasociliary nerve supply the tip and the side and the root of the nose and ophthalmic herpes zoster. The sign correlates strongly with ocular involvement, but there is no apparent correlation between the severity of the nasal rash and that of an ocular complication. So, one is that basically when there is a nasociliary branch involvement of the uh, with the herpes zoster virus, there will be the rashes that will be present at the tip of the nose, side of the nose. So this will suggest that there will be the this is a Hutchinson sign, and this suggests that there is a risk that an herpes zoster ophthalmicus will be present in such cases. So let's see figure 7.17a. So 7.17a is a Hutchinson sign vesicle involving the side of the nose. So you can see the side of the nose is also involved. So it means that it is a nasociliary branches involved. Age is a very important risk factor. Herpes zoster ophthalmicus occur frequently in the 6th and 7th decade. In the elderly, signs and symptoms tend to be more severe than in young and of longer duration. So as in any cases, age is a very risk factor for the any kind of disease. Age is also important in herpes zoster ophthalmicus keratitis. AIDS patients tend to have a severe disease, and shingles can be an early indicator of the human is an early indicator of the human immunodeficiency virus. So it tends to affect more in the cases of AIDS infected patient. A lower threshold of HIV testing should be adopted in population at particular risk. The development of shingles in children or young adults classically has prompted a search for immunodeficiency or malignancy. Though the requirement of this has been questioned as an abnormality which will be found in only a small minority. Tip vesicle involving the tip or side of the nose precede the development of the ophthalmic herpes zoster. It is very important. So in this case, when HGV is developing in the cases of children, then we have to look for the signs of the immunocompromised status, because it is not it is a risk factor for the presentation of the herpes zoster and ophthalmicus. So we will see figure 7.17b is showing the erythema and edema. The swelling on the right side right is not a sign of infection on that side. C is showing the vesicular stage. You can see the vesicles, small papules, mixed vesicular and pustular rash beginning to show crusting. Now it is have slightly showing crusting, and note the bogey edema affecting the medial part of the porta lid. Severe rash in a patient with AIDS. So this is showing how the AIDS affect the patient. This is a very severe rash of herpes zoster ophthalmicus. Typically healed appearance with mild and moderate scarring and depigmentation. Now is acute shingles. What are acute shingles? So clinical journal features. A prodromal phase is a phase basically in which the virus, in which there is no signs and symptoms, but the patient is um, usually affected. The prodromal phase precedes the appearance of the rash. So basically, before the appearance of the rash, it is called a prodromal phase. It lasts 3 to 5 days and it is characterized by tiredness, fever, malaise, and headache. Symptoms involving the affected dermatome vary from the superficial itching, tingling, or burning sensation to the severe boring or lancing pain that is either constant or intermittent. Older patients with early severe pain and a larger area of involvement are at particular risk for forced herpetic neuralgia. So, in this case, when the patient has acute shingles, there will be a patient that will be present with a fever, malaise, tiredness, and there can be an itching of an area that of the dermatome that is going to be involved. Now, how will the skin lesion look like? The painful erythematous area with the maculopapular rash develop and may be confused with cellulitis and contact dermatitis. So basically, painful mean the area is painful. Erythematous mean red. So macular papular rash is basically the area where there is no pustules, but there will be the redness, generalized redness in that area. So it can be confused with the cellulitis and dermatitis. But it is very important the rash respect the midline, which may aid in distinguishing shingles from the HSV in skin infection. Pain is also markedly worse in shingles. Bilateral disease is very rare. So very important the HZV typically is unilateral. It does not crosses the midline. If it crosses somewhat midline, it is not HZV, it is HSV. Within 24 hours, group of vesicle appear and they may be confluent over 2 to 4 days. So after 2 to 4 days, what happens that the area of redness area, there will be the appearance of a small vesicles. Although the rash itself is not affect the lower lid in the HCV, bogey edema of the upper and lower eyelid is common and often spread to the contralateral side of the face. Rash, if even if does not involve the lower lid, there will be the edema. There can be the edema of the eyelids, and even the edema can spread to the contralateral side of the face. The vesicle often pass through a pustular phase before they crust and dry after 2 to 3 weeks. Then there will the vesicle, the small vesicle will become pustules, they're pus-filled vesicles, and then after that they become crusting and then they become dry after 2 to 3 weeks. Large, deep hemorrhagic lesions are more common in immunodeficient patients. The lesion heal to leave a residual skin destruction and depigmented scar. So if there is a depigmented scar, the patient the lesion has been healed. Zoster sign herpeti is shingles without rash and may be more common than previously realized. So there will be no rash, but there can be shingles. Zoster, disseminated zoster. Disseminated zoster is when it involves the systemic involvement. Disseminated zoster involving multiple dermatomes and organ system may develop in immunodeficiency or malignant or malignancy, and with the advent of the PCR testing, complications such as meningoencephalitis have increasingly been identified in immunocompetent individuals. So, when there is an involvement of multiple dermatomes, it means that that the infection is disseminated. Investigations. In the event the clinical diagnosis is uncertain, typically in immunodeficiency, a vesicular fluid can be sent for PCR or immunomicroscopy. Basically, this is an clinical diagnosis, but if the clinical diagnosis cannot be made, then we can do PCR in such cases. A viremia lasting a few days occur in acute shingles. PCR of plasma for VZV DNA may be positive 40%, especially in immunosuppressed patient, and can be particularly useful if zoster sign herpeti is suspected. IgM antibodies to VZV are found only in minority of early stage and convalescent patient. So basically, the patient is trying to, so the writer is trying to say that IgM antibodies of VZV is found only in small amount of patient in acute stages or when there is chronic phase, and the PCR may be present only 40% of the time in immunosuppressed patient of a plasma. Now, what are the treatment we given in case of herpes zoster in acute shingles? Means that is affecting the skin, I think. Treatment. Oral antiviral treatment optimally given within the 72 hours of rash onset reduce the severity and the duration of the acute on episode and the risk of post herpetic neuralgia. So if the treatment is started within a 72 hours of development of rash, then there will be the less acute episode of acute episode, and also there will be the less chance of post herpetic neuralgia. The incidence of late ophthalmic complication is also reduced by 50%. Patient presenting later than 72 hours but still at vesicular stage are also derive benefit from the treatment. So patient who are so we discussed that there will be the first, there will be the maculopapular rash, then there will be the vesicular stage, then there will be the pustular stage, then there will be crusting, and then there will be drying. So if the patient present in a vesicular stage, then it can also reduce the complication chance by 50%. Acyclovir 800 mg 5 times daily for 7 to 10 days have been the mainstay of treatment, but the newer agents such as valacyclovir 1 gram 3 times daily or famciclovir 250 to 500 mg 3 times daily have more convenient regime and are better tolerated and are at least as effective as acyclovir. So basically its regime is 800 milligram for 5 times a daily for 7 to 10 days, whereas in HSV it was 400. And other alternative regimes are valcyclovir and famciclovir. Brividone is available in some countries. Fatal interaction with 5-fluoropyrimidine have been reported, and it should not be used in combination with even regional 5-fluorouracil. So we do not use it with 5-fluorouracil because of its fatal interactions. Intravenous acyclovir 5 to 10 milligram per kg 3 times daily is generally indicated only for severe disease, particularly encephalitis or moderate to severe immunocompromised. Basically, the IV regime is only given when the patient is immunocompromised and or having a systemic associations. Systemic steroid, for example, prednisolone 60 milligram daily for 4 days, then 40 milligram for 4 days, and then 20 milligram for 4 days remains somewhat controversial but are commonly used in moderate to severe disease, particularly for neurological complication. They should not be given in only in conjunction with the systemic antiviral and should be probably avoided in immunodeficiency. A moderate reduction in acute pain and accelerated skin lesion is confirmed, but steroids have no effect on the incidence or severity of the post-herpetic neuralgia. So basically, it is used for the ongoing inflammation, but it is very controversial role of this. Immunocompromised patient require the input of an infectious disease specialist. Antiviral treatment should be extended and intravenous treatment may be optimal. Systemic steroids should be probably be avoided. Symptomatic treatment of skin lesion is by drying, antisepsis, and cold compression. So this is our all symptomatic treatment. The benefit of the topical antibiotic steroid combination is uncertain. Patient with shingles can transmit chickenpox, so the contact with people not known to be immune, particularly pregnant women and immunodeficient individuals, should be avoided at least until crusting has been complete. VZV uveitis is considered in depth in chapter 12. So it is very important part, it will deal in chapter 12. Prevention. Vaccination against herpes zoster reduces the incidence of HZO. Two vaccines are available and both are approved for individuals over the age of 50 years. Zoster vaccine live is an attenuated live virus with an important limitation that efficacy is lost within 10 years. Recombinant zoster vaccine requires two injections and has a 10% incidence of the local or acute systemic reaction. So as we remember that in case of HSV we give prophylactic acyclovir, but in case of VZV we can give vaccination for the prevention. So now we are going to study about the eye disease. Now we are going to study acute eye diseases, chronic eye diseases, and the relapsing eye diseases in case of the herpes zoster keratitis. So uh, eye diseases, acute epithelial keratitis develops in about 50% of the patient within 2 days of onset of rash and usually resolves spontaneously within few days. It is characterized by the dendritic lesion that are smaller and finer than herpes simplex dendrites and have a tapered end with terminal bulb. Terminal bulb. The lesion stain better with rose bengal than with fluorescein. Treatment, if required, is with topical antiviral. So now we are seeing the acute signs of the herpes zoster virus. So in case of herpes zoster virus, it involves a different layer of the cornea. In case if the epithelium is involved, it causes the dendritic lesion. But in contrast to the herpes simplex, it involves the periphery and it does not have a terminal bulb, and it stains more readily with the rose bengal than with fluorescent, and the treatment is with antivirals. Conjunctivitis. Follicular or papillary is common and often occur in conjunction with the lid margin vesicle. Treatment is not required in the absence of corneal disease, though some practitioners give topical antibiotic and or antibiotic prophylaxis. So if there is a skin vesicle, then there may be associated follicular conjunctivitis with herpes zoster virus. Next is episcleritis and scleritis. Episcleritis occur at the end of the rash and usually resolve spontaneously. A mild non-steroidal anti-inflammatory may be used if necessary. Scleritis and sclerokeratitis are uncommon but may develop at the end of the first week. Treatment of indolent lesion are with oral flurbiprofen 100 mg thrice daily. Oral steroid with antiviral cover may be required for severe involvement. So if there is an involvement of the episclera, we give, due to herpes zoster, we give topical NSAID. But in case of scleritis, we give oral NSAID, and if the lesion is very severe, we give oral steroid with antiviral cover. Nummular keratitis. Nummular keratitis usually develop at the end of the epithelial lesion about 10 days after the onset of rash. It is characterized by fine granular subepithelial deposits surrounded by the halo of stromal haze. The lesion is fade in response to the topical steroid but recur if the treatment is discontinued prematurely. So now it is now involving the layers of the cornea. Now basically the nummular keratitis is when there is a so it is an epithelium. It is a subepithelium and there is a surrounding haze. So it is called nummular keratitis and it responds to the topical steroid. So just remember that if the epithelium is intact and there is no epithelial involvement, all other layers of the cornea, if affected, is being treated with the topical steroids. Now, stromal interstitial keratitis develop in about 5% 3 weeks after the onset of the rash, and significant scarring can occur. It usually responds to topical steroid but can become chronic and requires slow tapering. So, in case of this stromal keratitis, it also responds to the topical steroid. Deciform keratitis, immune mediated endothelitis, is less common than with herpes simplex infection but may lead to corneal decompensation. Treatment is with topical steroid. So, we will see figure 7.18. So 7.18 show the acute lesion in herpes zoster ophthalmicus. A is showing the dendritic epithelial lesion with tapered end stained with fluorescein. B is showing the dendritic epithelial lesion stained with rose bengal. C is showing us a nummular keratitis. D is showing the stromal keratitis. Anterior uveitis affect at least third of the patient and can be associated with the sectoral iris ischemia and atrophy. So just remember, in case of herpes simplex virus, it causes the patchy iris atrophy, and in herpes zoster virus is called the sectoral iris atrophy. Posterior uveitis. Posterior uveitis, progressive retinal necrosis, is an aggressive retinitis usually occurring in immunodeficient individual. Acute retinal necrosis can also be caused by VZV. So there is a disease called PON, posterior outer retinal necrosis, which is caused by the herpes zoster virus and in an immunodeficient patient. We will discuss this in more detail in a chapter of uveitis. So this is a figure 7.19 that is showing the chronic lesions in herpes zoster ophthalmicus. A is showing the scarring with the lipid degeneration. B is showing the sectoral iris atrophy. C is also showing the sectoral iris atrophy. D is showing the scleral atrophy, and E is showing the staphyloma with the severe corneal scarring, and D is showing the mucus plaque keratitis. Posterior segment examination should always be performed in a patient with HCO, as retinal vasculitis may occasionally occur. IOP should be monitored as elevation is common, including steroid induced. So there are two major methods. Uveitis can be caused increased IOP and steroids. Prostaglandin derivative should be avoided if treatment necessary. Neurological complications. Neurological complication may require intravenous antiviral and systemic steroid. So IV antiviral plus systemic steroid if there is a neurological complication. Cranial nerve palsies affecting the third most common, fourth and sixth usually recover within 6 months. Optic neuritis is rare. CNS manifestations are rare but include encephalitis, cranial arthritis, and Guillain-Barré syndrome. So most common, it is a very important MCQs as well. That what is the most common nerve that is being involved in herpes zoster virus? It is the third cranial nerve. Now, what are the chronic eye problems associated with herpes zoster virus? Chronic eye disease. Neurotrophic keratopathy is similar to that seen in HSV infection, develop in about 50%, but is usually relatively mild and settles over several months. Prolonged severe disease occur in a minority. So I told you in the start what is the mechanism of the neurotrophic keratopathy. Basically, there will be corneal anesthesia due to the destruction of the nerves by the herpes zoster virus. Next is scleritis may become chronic and lead to patchy scleral atrophy. Staphyloma formation is rare. So if the scleritis is due to HSV, it can lead to the chronic condition known as patchy scleral atrophy or staphyloma formation. Mucus plaque keratitis develop in about 5%, most commonly between the 3rd and 6th month. It is characterized by the elevated mucus plaque staining with rose bengal. Treatment involve a combination of the topical steroid and N-acetylcysteine. Untreated plaques resolve after a few months, leaving a failed diffuse corneal haze. So, in case of a mucus plaque keratitis, which is basically the mucus that is attached to the epithelial cells, they stain with the rose bengal, and the treatment is steroid and acetylcysteine. Lipid degeneration may develop in eyes with persistent severe nummular or deciform keratitis. It is very important that a lipid degeneration is basically the lipid deposition that occur after the chronic inflammation due to the herpes zoster virus. Lipid filled granuloma is similar to those resulting from a chronic irritation, may develop in a tarsal conjunctiva and may progress to erosive calcified concretions. Subconjunctival scarring may occur. Eyelid scarring may result in ptosis, cicatricial entropion, and occasionally ectropion, trichiasis, lid notching, and medarosis. So these are all the chronic complications after the HZV. Relapsing eye disease. In the relapsing phase, lesion may reappear years after an acute episode which may have been forgotten, and eyelid scarring may be the only diagnostic clue. Reactivation of the keratitis, episcleritis, scleritis, and iritis may occur. So we can get the clue that the disease is relapsed because of the previous eyelid scarring. Now, very important, post-herpetic neuralgia. Post-herpetic neuralgia is defined as a pain that persists for more than 1 month after the rash has healed. So basically, after a month, 1 month, it develops after post-herpetic neuralgia. It develops in about 75% of the patient over 70 years. So 75% times it occurs if the patient is greater than 70 years. Pain may be constant or intermittent, worse at night, and aggravated by minor stimuli, allodynia, touch, and heat. It generally improves slowly over time, with only 2% of the patient affected after 5 years. Neuralgia can impair the quality of the light and may lead to depression of sufficient severity to present a danger of suicide. Patients severely affected should be referred to the specialist pain clinic. Treatment may involve the following. So in case of the post-herpetic neuralgia, basically the nerve that involve a dermatome gets irritated. When it irritated, the patient may feel burning, itching, and intense pain in the area of that dermatome. So what are the treatment? Local is the cold compresses, topical capsaicin 0.05% or lidocaine 5% patches. Systemic treatment may be used in a stage fashion. Simple analgesics such as paracetamol, stronger analgesics such as codeine, tricyclic antidepressant, for example, nortriptyline, amitriptyline, initially 25 mg nightly, adjusted to 75 mg for several weeks if necessary. Carbamazepine 400 mg daily for lancinating pain. Gabapentin 300 to 600 mg up to 3 times daily, or sustained release oxycodone 10 to 30 mg twice daily, or both. So basically it is not telling us that we should give all of them. So there are some treatment when we can do locally on the skin. We can ask the patient to do cold compresses of that region, and also can give a topical capsicum or the topical lignocaine cream for that. But if the systemic treatment is necessary, we do it in a stepwise fashion. First we give paracetamol. If that is not affected, we give codeine. If that is not affected, we give TCA. If that is not affected, then we give add carbamazepine. If that is not affected, then we give gabapentin or sustained release oxycodone. So that's it for the cornea part 9. Thank you very much.